Welcome to The View on GU, the place to be for translating uro-oncology knowledge to action. Here are your hosts, Drs. Ali Khan Lalani and Christopher Wallis.
It's Friday, January 26th, day 2 of GU ASCO. Welcome to The View on GU. I'm Chris Wallis, here with my co-host, Ali Khan Lalani, and we're thrilled to be talking about urothelial carcinoma today. So a little bit of level setting, a lot of data, but a couple of big categories we can maybe look at. We've seen, a couple of big abstracts in the first-line metastatic space, and really some evolution of data, I would say, in the adjuvant space. So maybe, Ali Khan, take us your view. How do we look at, the new data and the updates of data in the metastatic space? So maybe,
Yeah, no, thanks, Chris. It was a great, day one. And I think on the day two, we got to see, as you said, a really urothelial or bladder focus. I think the first abstract, as you mentioned, was looking at first-line advanced disease and really the subgroup analysis updates from EV302. So just to remind folks, this was a large randomized phase 3 trial that really read out in ESMO and caused quite a stir with, standing ovation on how the data read out. To remind folks, this was a trial against platinum doublet treatment. And really, it showed a significant improvement in overall survival and PFS, essentially changing the standard of care. To remind people, the PFS was improved from 6 months to about 12.5 months over chemotherapy with the combination of EV and pembrolizumab. And importantly, the overall survival showed a benchmark of around 32 months versus 16 months approximately for chemotherapy. Again, huge landmark achievement. What we saw just today, we're fresh off of the oral presentation, was some of the important updates in subgroups. Part of these subgroups I think are clinically relevant. How did patients do if they were cisplatin eligible or not? How did they do if they had visceral metastasis or liver metastasis? And I think it was really reassuring just to see that almost across the board for hazard ratio of improvement for PFS was in the 0.45 range, really maintained. And I think it was the same theme with survival, that most of these benefits were somewhere in the 0.47, 0.5 range, really significant improvements. Nothing really deviating that makes us concerned, and I think actually really preserves the top-line data we saw. That's really, really reassuring updates of some clinically relevant subgroups we see in clinic. And we wonder, how will these patients benefit? So, I think for me, my takeaway is this is reassuring, and the question becomes about really having this accessible in our clinic.
Absolutely. And so to me, as a non-prescriber probably of these drugs, I was really taken aback with the consistency. It was like you could take your hazard ratio out of any one of the subgroups and just flip it over into the other, and it didn't modify in any way. And I think that was a really interesting conclusion or result when we think about trying to personalize care. We're trying to look for subgroups that we're most interested in, and we're seeing that all of them are benefiting, right? All patients are getting this really profound PFS and OS benefit. And even in the worst players, we're really seeing that significant gain.
And I think you learn a lot about the granularity of, how the control arm does when you look at, some of these follow-up data, right? So we got to see if people are interested, and certainly this is available online. We can share the links to this in our podcast and YouTube channel. But essentially, the benchmarks of where we expect a control arm to perform for some of these patients that have, liver metastasis or unfortunately aren't able to get cisplatin. I think we learn a lot about them. But, either way, this shows such a remarkable improvement. To me, I think for at the time of recording, we don't have a clear approval in Canada yet. EV pembrolizumab was approved in the US. And so I think we're really looking forward to, in a Canadian and really multiple other countries are waiting for approval. There was a good comment about, will there be global equity and access to this kind of combination? I'm curious to see that. I think it's important. There becomes questions about what will we do next if we have access to these patients. I suspect it will be the kind of current standard of care, platinum and gemcitabine, will become the new subsequent line treatment. But I do think we are keen to see some sort of filing and approval, or at least an NOC, I would hope in 2024. And I think having access as soon as possible. This was a drug brought forward by Seattle Genetics, acquired by Pfizer, all publicly available knowledge now. And so, we will want to see this available for our patients. But again, another excellent presentation, preserving a lot of the impressive outcomes we saw.
Absolutely. And so you alluded to it here. There may be questions of places in the world or certainly time periods where this drug isn't available. And so I think this is the second time now that EV302 data is maybe cast a shadow that someone else has had to present within. We saw, the Checkmate 901 data at ESMO, and we had another phase 2 study looking at a very similar disease space, a similar patient population, maybe a subset of the EV302 cohort with the PEMCAB data. And what's your take on the role maybe of TKIs in these bladder patients?
Yeah, no, I mean, for context, this was the pembrolizumab and cabozantinib phase 2 trial, largely out of the US, taking patients who were deemed really cisplatin ineligible, but high PD-L1 by a CPS score of 10 or more, or being entirely platinum ineligible to receive pembrolizumab and cabozantinib at the 40 milligram dose. Now, the zoom out on this is that, these patients prior to EV302 would have had some jurisdictions having approval of single-arm pembrolizumab, not reimbursed in Canada for this indication, but hence that's the inclusion, right? Why does the PD-L1 status matter or not? And that was really how it was built. But essentially, this was a phase 2 trial built on response rate and really showed, nicely that there was good responses in the order of 45%. And, for really background that chemotherapy in this context might give you a 1 in 3 or 35% response rate. Pembrolizumab alone might give you a 1 in 4 or 25%. So to have a response rate in a small trial, 36 patients, of whom 35 were, really observable for response, I think was encouraging. And you look at the clinical benefit rate of CR, PRs, and SDs, again, for a population that really didn't have other good options. I think at the time, a clinical benefit rate of 71%, a median PFS of just over 7 months, median OS in the 17-month range, I think was quite nice to see. I mean, countered by, 50% grade 3 or higher adverse event rate. So I think it was a very laudable study at the time. I think part of the next question becomes probably context and where do we take this? My 2 cents on that is, we've had trials like LEAP-11 looking at lenvatinib and pembrolizumab, another TKI in this population. We had a large phase 3 trial, negative study. Are there differences in TKIs? Possibly. Caveats that this was a small, phase 2 trial. So it's hard to really draw a lot of conclusions on that. But, I think to me, the larger question becomes, are there alternate TKIs? Angiogenesis has been targeted for a lot of urothelial cancer studies over many years now. Hasn't really broken the bank to be a standard of care. There are comments made by the discussant about, access in terms of trials. Main CAV study, which we are trying to support in Canada, a large, cooperative group study led by Shilpa Gupta on, combining maintenance of avelumab with cabozantinib. So there might be a place for TKI somewhere. I think it's important to study, but right now, I think the zoom out for me is patients who are cisplatin eligible or ineligible, who can get some form of systemic therapy, appear to benefit from getting EV and pembrolizumab. So I think really, if you ask me what I'd want tomorrow in clinic for my patients, it'd be that combination.
Right. And we're not that far off, I think, is what I'm hearing.
Yeah. I mean, I think the timing of some of these approval appear to be anticipated in 2024, and it might be in the back half, but this will be really highly anticipated. And that's a good point you make, Chris, is that this is not available tomorrow based on our recording day in most clinics. So there are still patients that will be appropriately receiving platinum gem, maintenance of avelumab if they do benefit and have a clinical benefit of stable disease or better. So I think that really is the tomorrow. But the horizon scan, as you say now, having back-to-back conferences with a novel combination treatment, I think it will be EV Pembro. I think for probably a separate discussion and not for today's podcast necessarily is going to be management awareness of toxicities, dose and schedule alterations if we need.
And what
recognizing,
next, I guess, is the other thing, right?
Yeah.
You've gone through IO, you've gone through, an ADC, and now are you going back to chemo?
And what next? Yeah, I mean, I think I've hinted at this. I think the platinum gem would be a very reasonable next option. But again, in light of the side effects patients may have on the first line, we need to make sure they are well enough to get that. Because at the end of the day, these survival estimations and benchmarks are essentially on the premise that these patients can get effective life-prolonging therapy as much as possible along their trajectory. So having the first line, you really need to follow that up with effective line options thereafter. So recognizing side effects and managing that, I think we could have a whole separate conversation on that. But, that will be the challenge in clinic, is making sure everyone is upscaled in terms of their knowledge and ability to recognize these patients, give them good effective treatment, have the patients call in and deal with that. And I think we can. We have good experience with enfortumab as a single agent in subsequent line settings, but we're quite eager to get this as a first-line option.
Totally. We saw, a little sidebar from Monty Paul today about, that value of supportive care. And, I think as you come with new agents, new toxicities, that value of supportive care and the ability to help patients through that process, I think is a real learning ground for all of us.
100%, because the reality in clinic is more than just the interventional drug. It's the whole concept that patients, in addition to effective anti-cancer therapy, need best supportive care. They need to be palliated appropriately in a metastatic setting. And there's a lot of support that goes around that to have them achieve benchmarks or exceed these benchmarks that we hope. So, to me, that was really the takeaway from the orals of the metastatic setting. So again, updates from known data, some new data, and I think it really reaffirms what we're looking for in 2024. I think the next context that was really hit on in this oral session was the post-operative setting, the so-called adjuvant setting, with the ambassador presentation. Chris, why don't you take us through that? Set the context for a little bit for our listeners and viewers, is that we do have adjuvant treatment available now in Canada and many places around the world to receive post-surgically adjuvant nivolumab. But we learned something new today. Maybe take us through that.
Absolutely. And so I think, this is a great disease space to really highlight that value of the multidisciplinary collaboration. Totally. These are patients that are going back and forth between medical oncologists and surgeons. So, in the pathway of a patient who's going to be eligible for this trial, you're going to start off in a urologist clinic. You're going to have hematuria or bladder mass. You're going to get your TUR. You're going to have, muscle invasive diagnosis. Ideally, in the eligible patients and most of the patients in this trial, you're going to get neoadjuvant chemo under the care of the medical oncologist. You're going to bounce back into the urologist's care for surgery. And so, when we think of who these patients are, we're looking at among the patients who were able to get neoadjuvant chemotherapy, those with residual muscle invasive disease, so YPT2 or greater, those who have node positivity, and a little bit uniquely in this trial, those who had positive surgical margins. And we can talk about that a little bit. Now, there's a subset, obviously, of patients who don't get neoadjuvant chemotherapy, and that may be for a variety of reasons. Maybe they're not eligible for cisplatin. Maybe, there's just their preference or the practice. And in those patients, we still want adjuvant chemo if we can get it. So the subset here who didn't have neoadjuvant, who are included also are those who couldn't get adjuvant chemo for whatever reason. Either they refused it or they couldn't receive it. And so in those patients, because they didn't receive any pre-surgical therapy, the bar was a little bit higher. So this is not just muscle invasive disease, this is PT3 disease, again, or node positivity or positive margins. And so when we look at these cohorts in Ambassador, we're seeing about 2/3 of patients getting the neoadjuvant chemotherapy, as I alluded to. We have a pretty high representation here of upper tract disease, so between 20 and 23%. And I think that's pretty noteworthy. It's a slightly worse prognosis subset of patients, and people who really probably benefit from those multiple lines of systemic therapy. And the headline data, this is a co-primary endpoint study. So we have these patients randomized either to pembrolizumab for a year or to observation. And after this year of therapy, we're looking at DFS as our sort of primary reported endpoint here, with the co-primary endpoint of OS, which we'll talk about, but is a bit immature so far. So DFS, The headline result here is about a 31% reduction in event rate. Conversely, 30 to 30% improvement in disease-free survival for those getting pembrolizumab. And what that translates to here is like 15 month difference in median DFS. So 14 months in the observational arm, 29 in the pembro arm. And I think that's interesting when we compare that to other data.
Yeah, remind us about Checkmate 274. So this was the similar study, similar inclusion, a phase 3 readout of nivolumab for a year versus placebo in that scenario. How does this compare to that?
Right. So the headline results, we still haven't seen OS, even though I think we're reporting now on we're 4 years past publication of this primary report, but we have an equivalent hazard ratio essentially, 0.7 in Checkmate 274. Interestingly, the patient populations obviously differ a little bit because you see the median DFS in that observation arm being down more like 10, 11 months in Checkmate, the nivolumab arm being like 21 months. But that difference, the relative difference, is still an equivalent essentially between the two trials. And so I think, overall we're seeing pretty reassuring results. This obviously is kind of maybe the adjudicator study on this whole concept of perioperative or adjuvant immune checkpoint inhibition, given that we had one positive trial, one negative trial. This maybe helps us understand the whole disease space a little better.
Yeah, I agree. I mean, I think, as you said, you've nicely summarized some of the DFS takeaway. I think for me, 3/4 of patients having lower tract disease, but as you said, nearly 1/4 having upper tract is impressive to see that there's, they're included and presumably still benefiting. 15% had mixed variant histology. And, the PD-L1 positive, which was kind of part of some subsequent endpoints, didn't seem to be predictive, but was prognostic. And I think that's critical because many jurisdictions with nivolumab approvals had selected based on PD-L1 and, essentially driven from the trial of their Kaplan-Meier curves showing the benefits. Some jurisdictions decided to select based on that. In Canada, we're fortunate to not have to need PD-L1 status, but I think this reaffirms that that's not. I think that's helpful to have on your pathology.
It's a counseling tool, maybe more than a treatment choice.
Exactly, and I think that's nice for us to be able to see another study saying essentially adjuvant immunotherapy for the patients you've mentioned are important. Some quick final thoughts on this abstract will be the censoring rate for DFS. 33.5% in the observation arm versus 19.8% in the immunotherapy arm. We've seen this in observation trials. A little bit more balanced for the censoring by OS. So, what do these patients have who are censored at DFS? I think we've talked a little bit about this. PD-L1 as a biomarker is challenging given immune cell versus tumor cell versus combination. So I think having bespoke ctDNA-driven trials will be potentially more informative. And then again, although upper tract patients were involved, I think we're starting to ask questions about will adjuvant immunotherapy benefit these patients uniformly as well as lower tract? I guess the other takeaway I would have is how do we make this work? And you've mentioned that important handoff. I think, there are some centers, certainly we're fortunate at ours at the Juravinski and other places as well that have multidisciplinary bladder clinics. So the flow might feel like a patient coming in with MIBC, meeting a urologist or uro-oncologist, a radiation oncologist, and a medical oncologist in same appointment. And we can kind of pass the baton, as I'd like to say. Patient gets neoadjuvant, ideally where applicable, if suitable to get definitive treatment with surgery. They can have a discussion of surgery versus radiation, but importantly, if they are having surgery, having an appointment or a referral back to the medical oncologist where you've highlighted where it makes sense, right? YPT2 or PT3, to then hear about adjuvant and receive adjuvant therapy. And so I think that's, a really important paradigm to play out. I mean, how do you see this in your context? You see referrals from your colleagues, potentially, or how it filters through academic centers. When you think about zooming out to the community context, what's the real takeaway for urologists based on another trial showing adjuvant IO provides benefit?
Absolutely. Well, I think it's about understanding who these patients are and making sure that you're appropriately referring. And so, thankfully, I would say over the last few years, we've had increasing uptake of neoadjuvant chemotherapy. And that's, a real benefit to our patients and a good thing in our community. And when these patients come back after their cystectomy, we're really focused on helping them recover. It's not an easy road. Maybe the surgical recovery is actually a bit easier in upper tract disease. The disease is bad, but the intervention is maybe a little less burdensome on the patients. And so, that's often a large part of it. But, remembering and really identifying this is the post-operative pathology that we're driving these decisions on. And our goal with neoadjuvant is really to downstage as much as possible. Mm-hmm. And so the people who get a great response to their neoadjuvant, maybe they're downstage to just superficial disease only, right? Non-muscle invasive disease. Those people don't need that adjuvant IO. These are really the people who have residual muscle invasive disease or node positivity. And so, understanding that cohort and getting them back in to see the medical oncologist in a timely manner so they can start those conversations about adjuvant therapy.
And on that surgical piece, I wondered, what was your thought on this trial having the inclusion of margin status? Like, what do you make of that? What's the reality? Can you educate us on the margin status in these type of surgeries?
Totally. So, we see that this is a small proportion of this cohort, right? It's like 2.5%. And really, when we're thinking about it, the whole design of the cohort and the inclusion criteria is trying to enrich for bad actors, right? People who are going to have a poor prognosis. In a urothelial carcinoma, a positive margin is a really bad thing. It's a bad surgical outcome to leave disease behind. Mm-hmm. And so it should be a rare outcome as well. We do not really see positive surgical margins at any considerable rate, whether upper tract or lower tract. I would say sometimes in the upper tract, you see those, bladder cuff with some superficial disease or some CIS. Yep. That's not what we're talking about here. Yep. We're talking about, real surgical margins leaving disease behind.
Yeah, so nice that they included it, but appropriate as well from your eyes as a urologist to see, that rate being pretty low. And I was curious to see that as well. And I think that's really hitting on the point, the importance of this perioperative space. These patients need to be managed and see multiple people. We haven't talked about, and not the focus today, about those patients who could, based on neoadjuvant chemo, benefit or be suitable for radiation. It's we can have a whole separate conversation on that, but it's the larger piece about, the majority of patients may undergo this surgery and to get them in the right hands for perioperative systemic treatment. I personally think as someone interested in this space, we're going to be moving up novel agents in a neoadjuvant/adjuvant setting. We're going to get some readout on that. I think blood biomarkers like ctDNA, clearance thereof may help refine these patients. So comments are made about some of these trials as not just the clinical outcome, which is super important, but we might learn something from all these innovative omics captured, tissue, blood, or otherwise. So I think there's lots of advancements in this space, and I thought it was a really important evening session to have. As we kind of get towards the end of this podcast, there's a full day. There's lots. It's impossible to cover it all, but we had a nice keynote lecture. Any takeaways you had today, Chris, otherwise?
Yeah, so I really liked the keynote from Charlie. I thought she did a fantastic job. And just to highlight, she was really emphasizing the issues with disparity in trial enrollment. And so, we've really highlighted fantastic data that come out of these clinical trials. But, one of the real benefits of clinical trials is that our patients get access to these really efficacious therapies before they're widely available. And so when patients in marginalized groups aren't included in trials, it both harms the population because they're not getting it, and it hurts us because we don't understand, how well these drugs may work in other populations. So, that may be a racial subgroup. We have lots of data where, pregnant women aren't included in studies, and we need, PK data. It's pretty rare in our cancer space, but, there's myriad of reasons why someone might not be represented. And she really presented some great data showing that even when you move to regions where you think there should be, abundant diversity, you go to Africa, and the majority of patients who are enrolled in clinical trials in Africa are white or Caucasian, right? And so we're really missing opportunities to understand how our drugs work in non-white populations, and we're missing the opportunity to provide those groups with access to these really, often great therapies years and years ahead of when they're otherwise going to roll out.
Yeah, I think it's super important. You mentioned that, and I'm glad it was a keynote. And even if you zoom out and say, okay, let's assume we get to a point where equity across clinical trials is there. One of the things I observe is there's clinical trial enrollment in many countries, but drug approval for these same drugs, where countries had the clinical trials, very much lags behind. So there's even inequity in locations that had trials to necessarily have timely access to that new standard of care. So I think this is going to be an ongoing discussion point, and one that we'll think about when we look at inclusion into trials, patient populations represented, and then countries that get the effective standard of care. So
totally. And the lowest bar is like just at least report what you're doing, right? She also highlights so many of these trials don't even give you a breakdown of the racial breakdown of the cohort. So at minimum, we need to understand what's happening before we can try and fix it.
Yeah, and it means what are you capturing in these CRFs, right? What level of granularity do you get to? So, another fascinating day as we come to the end. I think this was day 2 and our second recording. I think it's really exciting. We'll tease that tomorrow, day 3, is going to be the kidney cancer day. We're going to record immediately after the orals and try and capture all the data from the day in our recording. So, really thank you all for listening and watching. Don't forget to rate, review, and subscribe on our YouTube channel and our podcast, and engage with us on Twitter. We're at The View on GU. Let us know what you think, what you took away, and certainly what you'd like to hear about in upcoming episodes. For my co-host, Chris Wallis, I'm Ali Lalani. We'll see you on our next episode.